everyone, and welcome to the brand new Magnetic Resonance Imaging Clinics podcast series. I'm Stacy Eastman, the managing editor for the series here at Elsevier. MRI Clinics is a quarterly publication consisting of review articles focused on a central topic. Today, we will be discussing the February 2025 issue dedicated to MR imaging of the hip, guest edited by Dr. Jenny Bencardino. Here now is one of our consulting editors, Dr. Suresh Mukherjee, to lead the discussion.
Thank you so much, Dr. Mukherjee, and thank you to the audience for joining Suresh and I on this new podcast venture aimed to provide our readership with useful snippets and take-home messages extracted from the fantastic work done by our expert contributing authors in the field of MR imaging.
Great. Thanks so much. On today's episode, we're going to dive into some cutting-edge hip MR imaging. So, Dr. Bencardino, what are the most important recent technological advances in MR imaging the hip, especially the developments that are changing clinical protocols right now?
That is a great question. Hip MRI has seen some impactful advances over the last decade, which have reshaped how radiologists build their protocols. First, one of the biggest leaps is 3D isotropic fast-spin echo imaging. These are high-resolution volumetric scans that let you reformat the hip in any plane you want: coronal, sagittal, axial, even radial around the acetabulum, without having to acquire separate sequences. It gives better detail of the labrum and cartilage, and often shortens the overall exam because one 3D sequences can replace several 2D acquisitions. Another major advancement is quantitative cartilage mapping, like T2 mapping and T1 raw mapping. These techniques don't just show structure, they reveal the early biochemical health of cartilage before it breaks down. That means earlier detection of osteoarthritis, better surgical planning for things like femoroacetabular impingement or dysplasia, and more objective monitoring over time. We're also seeing the rise of MR fingerprinting, a newer technique that captures multiple quantitative parameters, T1, T2, even T1 raw, in a single accelerated scan. It makes comprehensive cartilage assessment far more practical in a routine clinical setting. We also need to talk about hip replacements and how we are getting around imaging metal, around hardware metal. So we have advanced metal artifact reduction sequences like Maverick and CIMAC. These approaches dramatically clean up the distortion around orthopedic hardware, making it much easier to evaluate soft tissues, infection, loosening, and osteolysis. A very different but exciting development is ultra-short TE and zero TE imaging, which lets MRI depict cortical bone, something that traditionally appeared pitch black. You can now get CT-like visualization of bone without any radiation, which is huge for younger patients and detailed preoperative planning. Then there is AI-enhanced MRI, which is touching both reconstruction and analysis. Deep learning reconstructions allow faster, high-resolution imaging, and AI-based segmentation helps analyze cartilage, labrum, and bone shape automatically. It's making advanced hip MRI far more scalable. And on the frontier, you got ultra-high field 7 Tesla MRI and PET MRI. 7 Tesla scanners deliver extraordinary resolution and even let you image other nuclei like sodium, which provides metabolic information about cartilage. So overall, modern hip imaging is moving towards high-resolution 3D imaging, quantitative tissue assessment, better artifact control, radiation-free bone imaging, and AI-driven efficiency.
Well, that's great. Let me, if you will, double click on the last thing that you mentioned, and that was specifically on artificial intelligence. There's a lot of things happening in radiology as a whole, but you did bring up some of the advancements and potential applications of AI. So, can you give me a little bit more information about how exactly artificial intelligence is transforming MR of the hip?
Artificial intelligence has reshaped hip MRI in three major ways. One, how we acquire images. Two, how we generate and process them. And three, how we interpret them. And each of these shifts is already changing day-to-day clinical practice. First, AI speeds up acquisition by improving reconstruction and automatically segmenting structures like cartilage, bone, and the labrum with near expert accuracy, making scans faster and workflows smoother. Second, on the generative side, AI can create synthetic images for training, simulate pathology, and even help draft reports, reducing bottlenecks and improving consistency. But the biggest shift is in interpretation. AI models can now detect labral tears, FAI, dysplasia, osteonecrosis, osteoarthritis, and even periprosthetic infection with accuracy that often rivals seasoned radiologists. So, what does this all mean moving forward? For clinicians, it means earlier and more reliable detection of hip disease, especially subtle or early stage pathology that used to be missed. That means better triage, more timely referrals, and more precise treatment planning. For radiologists, AI becomes a partner, not a replacement. It speeds workflows, reduces variability, assists with complex measurements, and frees radiologists to focus on higher level interpretation and clinical decision making. But it also means radiologists must stay in the loop since AI can still make mistakes that require expert oversight. In short, AI is making hip MRI faster, smarter, and more precise.
Great, thanks for that. So I have to admit, being sort of an old athlete, I interact a lot with a bunch of old athletes that think we're probably younger than we are and probably doing more than we should. And a lot of my colleagues have a lot of hip pains. And so I've got a lot of friends that play tennis and golf, and they're always complaining about something, usually about their golf game, but oftentimes they'll complain about their hip. The question I really have for you is that when someone comes to me and says they have potential hip pain and they're worried about some type of internal damage to their hip, what is the answer to the classic debate on the actual musculoskeletal imaging we should be doing when you're trying to diagnose a suspected labral tear in the hip? Is it conventional MR, MR arthrography? I know, as you mentioned, there's a lot of new innovations going on. But for today in 2025, heading into 2026, what should I be recommending my colleagues when they want to better evaluate a hip pain and they're worried about some type of internal damage?
Yeah, we should also mention pickleball before going on. Pickleball has become, all the rage, and we are seeing so many injuries associated with pickleball. But when we talk about diagnosing labral tears in the hip, the choice between conventional MRI and MR arthrography often comes down to how subtle the suspected pathology is and what question the clinician needs answer. From the data we have, conventional MRI performs well, with reported sensitivity around 90% and specificity around 85% for labral pathology. That means in many clinical scenarios, especially when high-resolution 3 Tesla scanners and optimized 3D sequences are used, non-contrast MRI can reliably detect most labral tears. However, when it comes to diagnosing labral hip tears, both conventional MRI and MR arthrography have value, but they are not really equal. A modern 3 Tesla MRI with high resolution 3D sequences can detect most labral tears and is usually the best first test to be performed. But if the tear is small, subtle, are not really sure on conventional MR imaging. The finding is really surgically important. MR arthrography is still the gold standard. So injected contrast material within the hip joint capsule helps distend the joint space, outlining the labrum and making tiny detachments far easier to see than on a standard MRI. So in practice, start with conventional MRI, especially at 3 Tesla. Use MR arthrography when MRI is equivocal or when high detail preoperative assessment is needed. And I would have to say, if you don't have a 3 Tesla scanner and you have a 1.5 Tesla, your patient is an athlete and the answer is really important to the clinician, do the 1.5 Tesla study, but with an MR arthrogram.
Thanks, Jenny. Another issue that comes up, and I've kind of seen this evolve over the last 25 or 30 years, is that I remember when we were just doing CT for hips many moons ago, and then MR started, and then we were pretty amazed that we could actually see the hip, and we could start looking at the hip anatomy. Then we were started looking at the marrow. And then as we got more and more detail, we were able to see things like the labrum. We were seeing things like the cartilage and look for cortical erosion on MR. And some of these new techniques in MR are going to allow us to better see the bone itself and specifically the cortex. So where I'm going with this is when you are looking at the hip, a friend of mine's actually husband just had a resurfacing technique instead of having a hip replacement. So now we're getting to the point where we can see incredibly wonderful detail of the hip. Given all of the anatomy that we can see on the hip and all of the potential areas of damage and degeneration and some of the newer techniques that could potentially avoid a formal hip replacement, do you have a checklist or a specific approach that radiologists should be taking when they are evaluating an MR performed for femoral acetabular impingement?
Well, the latest evidence says that radiologists should take a structured, clinically focused approach when evaluating FAI on hip MRI. So the first step is to look at the osseous morphology, especially looking for cam morphology, pincer morphology, or mixed type cam and pincer morphology. And we need to describe the location and the extent of these morphological changes, not just with a single alpha angle. I must say, I do not recommend making measurements of alpha angles, as there is a lot of inter-observer variability with this measure. Some people could tell me, well, my orthopedic surgeon really wants me to do this measurement because it will inform insurance whether or not a surgery will get approved. And in those cases, if you are working closely with your referrers, we do provide a measurement of the alpha angle. Next, after looking at the osseous morphology, we look at the labrum, and we pay particular attention to the anterosuperior quadrant where most of FAI-related tears occur. So that is important. That's an important checkpoint in the preoperative assessment for FAI. Next is the evaluation for early cartilage injury, because what we want to do with hip preservation surgery is to avoid the hip to go into advanced osteoarthritis. So the procedures are done for the prevention of cartilage degeneration. So the referring surgeon, hip preservation surgeon, needs to know that there is no great chondral damage yet for the procedure to be applicable. So we want to use high-resolution 3D or radial sequences to map the cartilage to a great extent. And we can also use biochemical imaging, as we mentioned before, to assess for early biomechanical changes. So in short, modern FAI interpretation is about integrating morphology, labral pathology, early cartilage damage, and also version into one clear, actionable picture for the clinician.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
Another potential area of misdiagnosis is developmental hip dysplasia on MR. I know sometimes that can be challenging. Do you have any tips from your own experience on how to avoid misdiagnosis of developmental hip dysplasia?
Well, I have to say, Dr. Luis Beltran, the author of this manuscript, Dr. Beltran and I worked on this topic about 10 years ago because we were concerned that people were so much into the hype of FAI that we were overlooking hip dysplasia. And mild changes of hip dysplasia in the early adult or even young adolescent are really, really important in order to prevent early osteoarthritis. So we want to avoid misdiagnosing developmental hip dysplasia on MRI, and we need to focus on a few key points. We need to first look carefully at the acetabular coverage. Dysplasia is often subtle, so we need to use multiple planes and radial views to assess under coverage, especially in the anterosuperior portion of the acetabular roof. I do not interpret an MRI of the hip without checking in the patient's folder for a well-centered APV of the pelvis, which allows me for measurements of center edge angle. And I perform these measurements on the X-ray and also on a large field of view coronal T1 if I have a T1, or if I have a large field of view stare, I do the measurements there. So that is the first step. What is the acetabular coverage in the patient? Do we have or not deficient coverage? Second, we want to assess the femoral and acetabular version and report the measurement method, since version abnormalities often coexist with dysplasia and can change the diagnosis. Very often we see, for example, coxa valga deformity in association with acetabular dysplasia, particularly in patients that have neurological disorders, cerebral palsy, for instance. Next, we need to study the labrum closely. In dysplasia, the labrum is hypertrophic. The reason for this patulous redundant labrum is that the labrum is trying to provide the coverage that the bone is lacking. So because the labrum is so large, and it cannot withstand the forces of weight bearing and torque, it ends up being torn very easily. And finally, we need to check for instability-related cartilage injury, and this is very typically located at the chondrolabral junction. So we need to follow the articular cartilage to the point where it meets the labrum, and in that location assess for delaminating labral chondral injury, what the surgeons call a carpet lesion, which is delamination of the cartilage from the subchondral plate that allows the chondral layer to be loose, and then when with the use of probe, it creates a wave, as you see a wave on a carpet. So in short, we need to combine coverage, version, labral changes, and cartilage patterns to build a full biomechanical picture, because dysplasia is an instability problem, and recognizing that prevents most diagnostic pitfalls.
Great. Thanks for that comprehensive reply. What instances is MR diagnosis of ischiofemoral impingement clinically relevant?
Well, that is a little bit of a loaded question, Dr. Mukherjee. The author of this manuscript is Dr. Martin Torriani. Martin described ischiofemoral impingement syndrome more than a decade ago. And since then, there's been a lot of discussion in the radiological literature about whether or not the syndrome has real implications that deserve a specific management. Just to give the audience a picture of what ischiofemoral impingement syndrome consists of, is we have a narrowing or decreased interval distance between the lesser trochanter and the ischial tuberosity, and the soft tissues that are located in between the intervening soft tissues are subjected to attritional changes that lead to edematous changes in the quadratus femoris muscle. We can see bursitis in this location. We can see also pathology related to the origin of the hamstring tendons. So in these instances where we have a specific involvement of soft tissue structures, say that we have a collection, a fluid collection, a bursa in that location, perhaps the needle aspiration of this collection could provide the patient with symptom relief. I think the controversy lies greatly on the diagnosis, the validity of measurements of the ischiofemoral interval, which have proven to be also very inconsistent. But definitely, if there is soft tissue pathology that could be addressed by the musculoskeletal imaging expert on the interventional realm, I think that definitely could be clinically impactful.
Great, thanks. Another question would be, what would be your diagnostic algorithm when interpreting MR imaging the hip in the setting of snapping hip syndrome?
Well, the diagnostic algorithm here has to do with whether or not the patient undergoes ultrasound evaluation before MRI, or MRI first and then ultrasound. And I think the right answer here is that once we have a patient who is experiencing clicking, popping, snapping of the hip joint, there are two main categories of pathology that can manifest in that way. One is intraarticular pathology. So we talk about labral tears, chondral damage, intraarticular bodies. So all these structures inside the joint can cause snapping, clicking, popping when they get interposed between the articular surfaces of the acetabular and the femoral head. The second category is extraarticular snapping syndromes. And Dr. Jenna Lee, in her manuscript, addressed specifically this extraarticular pathology. So we are talking about iliotibial band friction syndrome. We are talking about iliopsoas tendon snapping. And in those cases, on MR images that are obtained at rest, it's very difficult to determine whether or not they are causing the snapping, right? So in that realm, if we're seeing some edema interposed between the iliotibial band and the greater trochanter, or we are seeing some edematous changes around the iliopsoas tendon, the patient has snapping, the way to go is to recommend a dynamic ultrasound that will confirm that indeed the structure that we believe is causing the symptoms is doing so under direct visualization with the ultrasound probe.
Does MR imaging contribute significantly to the treatment approach for greater trochanteric syndrome? And if so, how does it do so?
So interestingly enough, greater trochanteric syndrome is a very, very prevalent condition. I would say out of every 10 MR examinations that I evaluate in a given readout session, 2 or 3 patients who are over the age of 50 are going to have pathology in the greater trochanter. So it's been likened to pathology of the rotator cuff at the shoulder. So you could think of the greater trochanter as you think of the greater tuberosity of the shoulder being the point of anchorage for the supraspinatus, infraspinatus, teres minor. In the greater trochanter, we have the gluteal tendons attaching into the different facets. So the gluteus minimus goes to the anterior facet. The gluteus medius has 2 attachments, one to the lateral facet and one to the posterior superior facet. And pathology that involves the insertional health of these structures includes tendinosis, partial tears, full thickness tears, greater trochanteric bursitis, subgluteal bursitis. And the diagnosis is readily made on MRI. And what MRI can inform the referring clinician is whether or not a image-guided, typically ultrasound-guided therapeutic injection with a mixture of anesthetic and corticosteroid will provide this patient with some relief and improve their life quality because the pain is really incapacitating. So it can help to inform interventional procedures, and in very rare cases, there is need to perform surgery on patients with greater trochanteric syndrome, but that can also be diagnosed with MRI if there is a very large retracted tear, particularly acute, where the surgeon can go in and reattach the tendon to the greater trochanter.
MRI. Great, thanks. What are the most recent insights and current concepts related to the anatomy of the proximal rectus femoris musculotendinous unit?
So this question is really, really important. The authors of this manuscript, as Dr. Sandra Mecho, Jaime Isar-Kepshul, and Ara Kasarjan, are well recognized, worldwide known musculoskeletal imaging experts in the area of musculotendinous disease. As a matter of fact, Dr. Kasarjan and Dr. Isar-Kepshul will be the invited guest editors of an issue on this topic next year, I believe, if I don't remember incorrectly. So the diagnosis of the variability of the rectus femoris complex has been brought to light recently by anatomic studies, anatomic cadaveric imaging correlation studies performed by the authors of this manuscript, particularly Dr. Sandra Mecho. And it is really important because there is, in musculoskeletal imaging, anatomy is really key, right? So if you don't know your anatomy, you don't know it really well, you are going to go down the path where you may confuse normal variants or anatomic variants with disease. So there are different patterns of attachment of the rectus femoris to the anteroinferior iliac spine, to the superior acetabular rim that I very exquisitely described in this article, and I recommend everyone to take a look and read.
Yeah, so getting back to those athletes like myself are probably doing too much than they should, and getting back to the pickleball injuries that you mentioned. How does MR impact diagnosis and treatment of some of these stress-related injuries that we may encounter, in particular to the use of maybe some grading systems?
Yes, that is really, really a key question because more and more we are seeing is stress-related bone injuries in athletes, particularly runners, marathon runners, long distance runners, um, patients who are engaged perhaps in recreational activities that involve weight bearing activities that put the hip at great risk for stress related injury. And I'd say many of these injuries are completely radiographically occult. So patients have, a great deal of pain. They've been preparing to run a marathon. They are pushing themselves through the pain to accomplish their goals. And then you image them with an X-ray, and the X-ray comes back as negative, and then they keep on pushing themselves, as we high performers like to do. We just push ourselves through the pain, and then MRI will be the most reliable imaging modality to tell that patient if they have a stress injury, and if it is only a stress reaction, which is the presence of reactive marrow edema at the site of the of the injury, or if we have already passed a threshold where the bone has sustained a level of stress that even if normal, it cannot withstand, and there is a break in the trabecular bone, and then there can be a break also through the cortex. And in the hip is clinically very important because if the injury happens at the level of the femoral neck, a complete femoral neck fracture is a disaster. So we want to make sure that we timely diagnose femoral stress fractures before they become a surgical indication. Basically, a patient is going to need a hip replacement if we miss a femoral neck fracture.
I'm Suresh Mukherjee, co-consulting editor of the MR Clinics, and today I've been speaking with Dr. Jenny Bencardino, and I'm happy to say and proud to say that she's my co-consulting editor and guest editor of this issue of the February 2025 issue dedicated to MR imaging the hip. Jenny, thanks again for joining me today to discuss your comprehensive issue on MR imaging in the hip. Jenny and I are thrilled to launch this new podcast series and look forward to hearing from our listeners and our readers. To learn more about this and our other issues, please visit mri.theclinics.com.
Yes, and I'd like to say goodbye to all our listeners, and we can't wait to have you tuning in for our next podcast.
Thank you for joining us for this edition of the MRI Clinics podcast series. For an exclusive discount on the issue we discussed today, focusing on MR imaging of the hip, visit us.elsevierhealth.com/expert. MRI Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms, Clinical Key, and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on X and LinkedIn and subscribe to the Clinics Review Article podcast wherever you get your podcasts.